So we should be recording now. So Maima, on to you.
Yeah, hi, my name is Maima. I'm the Education Officer here with MedSoc. I'm just making you aware of the education page that we've put up quite recently. We've added in resources from week by week at each specialty throughout medical school, from week 1, year 1 to finals, prescribing, and so on and so forth. So if you're not already aware, these resources are available for everyone. They're free, they're on the website, and they're all up there. So yeah, just a little notice about that. We'll be putting a feedback form into the chat function. I think it's also on the Facebook event as well. And then at the end, we can send you the slides and the recording over. So really appreciated if you could click onto that afterwards. I know it's a pain, but yeah, that's everything from me. So passing it on to our 2 speakers today.
Hello everyone, my name is Rishi. I'm F2 currently on radiology. Let me just share my screen. So this is going to be sort of in 2 parts. I'm going to do the first part. I'm just going to go through just how to basically interpret an X-ray, just key things to look out for. And then Raz is going to do the second part. He's going to go through some clinical cases, just all the sort of main ones, the more common ones that might come up in exams and also when you're in hospital as well. So just some general principles, just main things to remember. Most chest X-rays you actually see will be normal. So it's very important that you can recognize the normal one, because if you can do this, it will help you pick out all the abnormal ones when you do come across them. Always try and relate it to a clinical scenario. For example, if you see chest X-ray, you see a sort of an abnormality and opacity somewhere on it. Say, for example, they're feverish, got a new productive cough, then you most likely think that's a pneumonia or an infection causing that. But if they've got a 3-month history of a non-productive cough, hemoptysis, weight loss, it might lead you down the path of something a bit more sinister, like a cancer. And what I'm going to go through is very important to have a systematic approach in exams or when you're first on the wards and getting grilled by a consultant. The main thing they'll be looking out for is that you do have a systematic approach to it, so that you cover all your bases, even if you're sort of not coming to the right diagnosis. At least you're showing how you're working it out and going through it properly. Other important thing is to always compare it to previous scans that they've had. Ideally, you'd like to compare to previous X-rays, chest X-rays if they've had it before. But also if I've had a previous CT chest, you also can compare it to that as well. I'm not going to go too much into this. Just some basics about how X-rays work. Obviously, the more dense a structure is, the more the X-ray it's going to pick up, and that's why we can sort of differentiate between different structures on the X-ray. And also, when there's abnormalities in there, they're going to show up as a more dense part in comparison to the air. That's how we can pick up on these abnormalities. Again, I'm not going to go too much into the anatomy either, but it's just to show that when we're looking at chest X-rays, we're not just looking at the lungs. There are a lot of structures within a chest X-ray which we can look at, and we can pick out abnormalities on it. It's important that you do have a sort of basic understanding of the main anatomy, which is shown on a chest X-ray. This is just to kind of show that, remember, in the right lung, it's split into 3 lobes, in the left it's into 2 lobes. And it's important to remember that. I'll show you in the next slide here that they all overlap quite a lot. So when you're looking at an AP or a PA film, it's very hard to tell exactly what lobe it's in. So I'll come onto this later, but it's better just to put it into zones rather than lobes. As you can see here, on the left lung, for example, if it was somewhere in the middle on an AP film, it's impossible to say if it's in the upper or the lower lobe. And again here, just to show that they all overlap a bit, so try to avoid picking out a lobe. Usually just go with the zones. So as I said, it's very important to have a systematic approach. Use whatever one you feel comfortable doing. I know the Americans use pretty much half the alphabet to describe theirs, but one I've always used, and I think a lot of people use, Dr. Wright, and then A, B, C, D, E. The D for the patient's details, so what their name is, date of birth, always make sure you've got the right patient, what type of film, which I'll come on to, the time and date it was taken, and then rotation, inspiration, picture, and exposure. So I'll go through these a bit more. So the type of film, so it's either going to be a PA or an AP. We always would like, ideally, a PA. You might have to make do with an AP sometimes if the patient's very unwell, they're lying down in resus, you can't get them to stand up, or they've got pain or whatever. For whatever reason, they can't stand up and get a PA film. The problem with the AP films is the main one is obviously you can't accurately measure how large the heart is. It might give you the appearance that there is cardiomegaly when that could not be true. And also with the AP film, you can see the scapula within the lung fields, which can obscure things a little bit. And just remember, whatever film you're looking at, if you look at from the PA film, the posterior ribs will be a bit more distinct, but the other way around, if you're looking at the AP view, the anterior ribs will be a little bit more distinct. So this again just shows when we're looking at an AP projection, obviously the heart's an anterior structure, so that is why the X-rays hit that first, and by the time we get to the detector, it gives the appearance that the heart is a lot bigger than it actually is. So if we do have an AP film, I mean, sometimes the heart can just look very, very large, and you can just call it. But if it's kind of on the border, I would avoid calling it cardiomegaly, because it might not be. So also with the type of film, just got to be careful whether it's an erect chest X-ray or a supine. If it is, assume it's always erect, but if it is supine, it will clearly state on the X-ray that it is supine. And this is very important because when someone is supine, it can give, again, the appearance of cardiomegaly when it might not be true. And it also makes vascular markings a lot more prominent. And this is quite important because when I was on A&E, actually, there was a guy who he had to have a supine X-ray. So he was just because he had some back pain, he couldn't stand up for whatever reason at the time. So he had his X-ray. It's got it back. It was just around when COVID started going off as well. So everyone thought, oh dear, it's like a terrible X-ray. And we spoke to radiology about it. They said, well, it's because he's supine, so I reckon if we get an erect one, it'll be fine. And he was absolutely right. After we got the erect chest X-ray, which is like a completely normal X-ray, so just something to look out for and be careful with. You can also get lateral views. You won't see these much in hospital, but you occasionally see them, but rarely. You can, just behind the heart border, you can sometimes see areas of consolidation a little bit better. And if it's a small pleural effusion, you'll see it on the lateral view before you see it on the AP or PA view. So when we're looking at image quality, the first thing I always look at is the rotation. So it can be sort of vertically rotated. So if one shoulder's higher than the other, it'll be a little bit vertically rotated, but that's often not a problem. The problem is if it's rotated along the x-axis. So we always look at the spinous processes, and you want the ends of the clavicles to be equidistant from the spinous processes. You'll see here on the next one, if you look at the spinous processes in the middle here, they appear to be a lot closer to the left clavicle. I mean, the spinous processes are a posterior structure. So when they're closer to the left clavicle, it's because the left shoulder is more anterior than the right shoulder. And as you can see here, it just makes the film quality very, very bad. You can't read it as well as if it was not rotated. And with inspiration, as you know, when people have an X-ray, they're asked to take a deep breath in. And this is to help to visualize the lungs better. So you can either use anterior or posterior ribs when you're counting to see if it's any good. So it's 5 to 6 anterior, 8 to 10 posterior. Just I'd always avoid saying it's poor inspiration. Instead, I would say there's a decreased lung volume in the right picture, for example. And the decreased lung volume would either be, it might be because of poor intubation, but also might be that they've got a very fibrotic lung, they're quite restricted, and that's just their best inspiration that they can do. Picture, so essentially the main thing is, can you see the whole image? So I might ask you if, is there a small left pleural effusion? I'd say, well, I don't know because I can't see the left costophrenic angle, so it's impossible to say. So always make the costophrenic angles will always be the one that are most likely not picked up sometimes. So just be careful to look out for that. Another thing is the angulation. So if someone is lordotic, either they are lordotic, or the way they've just taken the X-ray, they're just in a bit of an awkward position. The clavicles can appear higher than they actually are. If you can see here, they are higher than they would be on a normal X-ray. The problem with that is that it's obscuring the apex of the lungs. So if it was an abnormality, then it'd be a bit harder to see. And then exposure. So just seeing how well penetrated the image is. If it's under penetrated, so I'll start with the normal one. So it's not a very good image, but if the perfect penetration, you just want to be able to see the spine behind the heart. Just only just though. If it's under penetrated, you can't see it at all. And the problem with these images is the pulmonary vasculature and the interstitial markings appear a lot more prominent than they actually are. So it might make you think like they've got some pulmonary edema or something like that going on there, when in fact it's just under penetrated. And then on the right picture, you can see it's over penetrated. So that means you can see the spine too much. And if you look at the lung fields, it's very dark and it's not very good, easy to read. So going on to, so after you're happy with the quality of the film, you go on to the A, B, C, D, E of this. So starting with A, so that with A, the main thing is the trachea. So is it central or is it displaced? Is it then after if it is displaced, is it pushed or is it pulled? So the way I think of it is anything that adds volume to one side of the hemithorax will be pushing the trachea away from that side. So for example, that'd be something like a tension pneumothorax or a massive pleural effusion or a mediastinal mass. And then anything that loses volume on one side of the hemithorax can pull it towards that side. So that would be your sort of pneumectomies, total lung collapses, and small pneumothoraces as well. I also as well will look at see if there are any paratracheal masses. You can follow the carina down to where it diverges into the right middle bronchus and right main bronchus and left main bronchus. Some people look at the hilum and the breathing part or the airway. It doesn't really matter as long as you cover it and it's part of your system. It doesn't really matter too much. It's usually around the T6 level. Left is usually about 2 centimeters higher than the right. And just looking there to see if there are any masses. And also you want to see if there's any foreign bodies lodged in the trachea or further down. So as you can see on the left image, so the trachea is pushed this is a tension pneumothorax, it's pushed away to the other side. And on this image next to it, it's a massive pleural effusion, which is pushing the trachea away from it. And then on this side, the trachea is being pulled towards this area, which is a massive whiteout, which is most likely caused by pneumectomy or a total lung collapse. And then just more detail on the hilar. So when we're looking at the hilar, if there's a mass there, we want to think, is that a true mass or is it a pulmonary artery dilation? So use the hilar conversion sign. And what that is, if you look at this image on the left, it looks like there's a bit of a mass in the right hilum. And the conversion sign essentially means that if you look just beyond it, the pulmonary vasculature all converges centrally. And if it looks, so it's all linked up and it all converges centrally onto the main part, which you think is a mass, then that would be a dilated pulmonary artery rather than a sort of a tumor or anything like that. But on the other image, you'll see there's the mass there, but it's nothing converging onto it. So you'd say that's more of a true mass. If there is a mass, then you can use the Hyler overlay sign to distinguish if the mass is within the hilum or if it's anterior or posterior. So this sign essentially, if the mass was within the hilum, you wouldn't see the markings of the pulmonary vasculature. It would lose its silhouette sign, which I'll come on to a bit later. But if you can still see the markings of the pulmonary vasculature, then that would mean that the mass is either anterior or posterior to the hilum. And then foreign bodies as well, you want to look out for those in the airway. Moving on to breathing. So the main thing is the lung fields, looking for areas of increased lucency and density. You want to be looking for symmetry, comparing them all. As I said earlier, avoid describing anything as being in a lobe. Just play it safe and say zones. So upper, middle, lower zone. You could also even add in apical zones for this. With all the fields, you want to be comparing them both, looking for the vascularity. Do the lung markings go all the way out to the peripheries? You can use this to see if there's any pneumophoreses. And then you want to be just, if you see any infiltrates, which I'll come on to, any masses, effusions, lobar collapses. And this is a silhouette sign I was saying earlier. So is that the silhouette sign is actually a loss of the silhouette of a structure. Silhouette, if you just Google it, it's when you have the structure and it's a complete contrast to its background, so it gives that lovely silhouette. But in terms of chest X-rays, it's a loss of that. So with the heart, it'd normally be a nice silhouette. There's a white structure on the black background. But if there's something on the border of it, then it loses its silhouette. So that would be the silhouette sign. So these are things you just want to be looking out for again when you're looking at the lung fields, any consolidations, interstitial markings, nodule masses. So it goes into two main categories. So you have the interstitial infiltrates, which can either be reticular-nodular or reticulonodular, which I'll come on to. These have relatively sharp, well-defined margins. You won't see air bronchograms. So things like pulmonary edema, fibrosis, metastases, TB, sarcoidosis. And then you have the alveolar infiltrates. This would you describe as consolidation. So this is the more fluffy, clouds-looking like infiltrates. You will often see your air bronchograms in this. So this is your fluid, blood, pus. And also note that the pulmonary edema can be interstitial and alveolar. You often will get the interstitial first, and then if the pulmonary edema gets worse, then it can cause alveolar opacification. So interstitial can further be broken down into reticular, which means too many lines, nodular, too many dots, reticular nodular, a bit of a mixture, and then reticular, you can break that down further into fine, so things like pulmonary edema, interstitial pneumonitis, and then coarse reticular, which when you get your honeycomb lungs, end-stage fibrosis and connective tissue disorders. And then nodular, so it's small or large, so you get a small nodules from fungal infections, silicosis, sarcoidosis, lung, and then larger nodules would be things like your Mets, lymphomas, sarcoidosis. You notice sarcoidosis is pretty much in every single one because it can be, and rheumatoid nodules as well. And then you'll notice this miliary pattern, which you may or may not be aware of. So this is smaller nodules, about 2 to 3 millimeters, and this is classical for TB. And the alveolar pattern you'll see is a bit more of a fluffy cloud-like appearance. And with this, you want to be thinking, is it focal or diffuse? If it's focal, it could be a sort of a primary cancer or pneumonia. More diffuse could be a severe pneumonia, COVID, or a more severe cancer. Air bronchograms. So I'm not sure if you're aware of these, but these are often, you get these and in the alveolar consolidation. So you get this because you have your air-filled bronchi, which are dark, which you can just see about here. And you can notice these because the alveolar is filled with fluid or pus or blood or whatever. And then that because of that, you can see that the bronchi is still patent, and it just creates a bit of a contrast there, and that's why you can see the air bronchogram. So you get that with infections. And the other thing when breathing, just want to look for pleural thickening, so for cancer or pleural plaques and things like that. Circulation, so mainly looking at the heart. So 2/3 of it should be on the left, 1/3 on the right. You want to be looking at the size of the big thing to look for, so the cardiothoracic ratio. If it's more than 0.5, then you can say that's cardiomegaly. Looking at the heart borders, is anything obscuring it? Have you still got that silhouette sign? You can also look at the great vessels as well. So this is a good picture of cardiomegaly. So when you use the computers in hospital, you can sometimes use a measuring tool to do it for you, but here you can quite evidently see that it's more than 0.5. So you can define that as cardiomegaly, but remember, PA only. If it's an AP, I wouldn't avoid calling it. Then the great vessels, so here you can see a thoracic aortic aneurysm, just another thing to look out for. Not the ideal way to diagnose aneurysms, but you can sometimes see them if they're quite large. Then D, the diaphragm. So you can see all these angles here. So you've got the cardiophrenic angles and the costophrenic angles. So you want to be seeing if there's any effusions or consolidation which are obscuring these. Remember that the left is always a bit lower than the right. That's because the heart's lying on it and pushing it down. Within the diaphragm, you'll be looking for some gastric, you might see a gastric bubble. The gastric bubbles are usually round, quite ovoid shape under the hemidiaphragm. Because the stomach has a thick wall, there's usually a thick wall separating it. In contrast to pneumoperitoneum, which is usually a crescent shaped, and usually a much thinner line, because the only thing separating the two cavities now is just the thin diaphragm, as opposed to the gastric bubble is much thicker line, as I said, unless it's obviously a large one here. But also the clinical history would be quite key in differentiating these as well, because if they have a pneumoperitoneum, especially like the one on the right, you'd expect them to have some pretty severe abdominal pain. And then everything else, so you want to go over the bones, any fractures, any dislocations in the shoulder and the clavicle, any lytic lesions, soft tissue, so just looking at the symmetry, masses, any subcutaneous there caused by surgical emphysema in this picture here. And then any lines and tubes, just comment on those at the end. This is obviously quite a busy chest x-ray, it's got every tube in them. So you can look for your ET tubes, NG tubes, Hickman lines, central venous catheters, all those sorts of things. You might see the cardiac monitoring on it. It's always worth just mentioning these at the end if you're asked about it in an exam or anything like that. And also just calcifications, be aware that you can see that was quite evident on chest x-rays. So well, on here, you can, if you look, it might look, when you first look at it, it might look like there's some consolidation or something dodgy going on here. But if you follow along, it goes along each rib. So these are costochondral calcifications. And another common place to get calcifications is within the great vessels. So just be wary of those. Yeah, that's it for the first part. I'll hand over to Reza. He'll go through some clinical cases just to help sort of, he'll show you sort of the common ones to look out for, which might pop up in exams and things like that. And stop sharing. All right, is there any questions before we move on?
Okay, thank you, Rishi. Can anyone hear me?
Yeah, I can hear you.
All right, so I'm going to go through some cases now. There are going to be some MCQ questions as well. You can participate by either writing in the chat box the answer, or you can write it down on a piece of paper, however you wish. So without any delay, let's go to case number 1. So we got a 32-year-old patient who presented with chest pain, some headache, some loose stools, feeling hot and cold. But he's had a history of anxiety, and usually when he feels anxious, he gets hot and cold. His CRP is about 20, his lymphocyte is about 0.6. This is his chest X-ray. So based on the clinical history and based on the chest X-ray, what do people think the most likely diagnosis is? So we can type it in the chat box if you want. I'll give you about 20 seconds. Is it CAP, community-acquired pneumonia, or heart failure, COVID, or lung cancer? Okay, so well done to those who said it is COVID-19. So what we see in COVID-19 is, in terms of chest X-rays, first of all, about less than 50% of the chest X-rays have positive findings for COVID-19, and it really depends on what stage of the disease are we looking at. Is it earlier stage? Is it later stage? Is it mild, or is it very severe COVID? So it is not very sensitive, and definitely it's not very specific, but it can help us diagnose COVID on some cases, even if the clinical picture points towards something else. So the thing that we can is very kind of specific for COVID on chest X-ray is something we call ground glass opacities, especially in the peripheral zones and usually affecting the lower lobes. So ground glass opacities are areas of high densities, as you can see here on the left side and the right side, which they are not as opaque as consolidation. So they're not as white as consolidation. You can see some vasculature, some long markings in between them. And in the case of COVID-19, as I said, they usually start peripherally, and then later on during the course of illness, they can turn into consolidations. So the picture on the right, if you have a look at it, it shows, and the top picture shows ground glass opacity on a CT. As you can see, it's a hazy, high density area with some long markings that are visible in between them. The one on the bottom is consolidation, which is quite a white, very opaque area. And that is the difference between ground glass and consolidation. In terms of COVID-19, usually what we see is it starts with peripheral ground glass opacities between day 1 and 5, and then it turns into consolidation around day 6 to 11. Then day 6 to 11, they are the most critical days from COVID-19, which means that either the patient can deteriorate or they can recover. Then after that, they either get worse or they regress back into ground glass opacities between day 12 to day 17. So this is a case of a patient who unfortunately died of COVID. The picture on the top left side, picture A, is a chest X-ray on day 5, which I'm not sure if you can see, but there is a very small area of ground glass opacity in the left lower zone. It's very small, it's not that big. Picture B is day 7, which shows that the ground glass opacity has become more diffuse in the left side. But there is still no evidence on the right side of the disease. Then on day 11, we see involvement bilaterally in both lungs. So there is some granulose opacities on the right side, and there is on the left side. But then we can see that kind of the left upper zone of the left lung, it is more kind of dense. So it is the opacity here has tended to consolidation for this patient. And in D, we can see that the opacities are mostly tending to consolidations. They're very white, and they're very diffuse, present bilaterally in most lung fields. And from here, unfortunately, it's a downward pattern, and things get worse and worse, and they become more and more dense and more and more diffuse. And unfortunately, the patient died on day 18. So just to summarize, it starts with peripheral ground glass opacities, and then that turns into densities, higher densities, which are consolidations. And then it can either regress back into opacities, or it can get much worse. Okay, so this is another case. Patient is coming with cough, fever, and feeling tired. What do people think is the most likely diagnosis based on this chest X-ray? I'll give you about 30 seconds to think about it. Is it COVID-19? Is it atypical pneumonia? Is it CCF or left lung collapse? Okay, so in this X-ray, we can also see hazy areas of increased density bilaterally, affecting the lower zones, more prominent on the left side. They're not quite consolidations, not as white, it's not as opaque. So it looks very much like COVID-19. However, this case wasn't COVID-19. It was a patient who had mycoplasma pneumonia, which is a atypical type of pneumonia. So before COVID, if we saw this pattern, bilateral changes, we would have thought this is a case of atypical pneumonia, something like chlamydia, legionella, or mycoplasma. And we used to do a combination of urine test and blood test to look for any of these microorganisms. But now that we are living in the COVID era, we are testing everyone with COVID first. So this patient's COVID test was negative. And if it is negative, it still doesn't mean necessarily that they don't have COVID. It could be a false negative. But then if that's the case and you see these lung changes, then you can also test for atypical pathogens as well, which look very similar to COVID on chest X-rays. Okay, so this is case number 3. Can anyone tell me what the abnormality here is? Okay, so yeah, I'll give you another 5 to 10 seconds.
There's a poll out now that people can answer.
Okay, so yeah, we can see that people have mostly got it correct. It's great. So this is a misplaced NG tube. As you can see, the NG tube is coming down, it's coming through the thorax in the midline, which is fine. Then it goes into the right bronchus, it quos there, and then it goes through the left bronchus and into the left lung. So this is something that you will see very regularly when you start a foundation program. Not this case, I mean, but by that I mean you will be asked to assess the position of NG tubes very regularly. And if you say, oh, this is fine to start feeding for this patient, this would be a never event. So we need to be very careful about these. There are 4 parameters that we need to consider when we are assessing the position of NG tubes, and all 4 of them must apply. So the first one is the NG tube should pass through the midline, through the thorax. Then it should bisect the carina and doesn't change course, okay? As if it doesn't care about the carina at all. So it should just go straight down at that point. Then it should go through the diaphragm in the midline. Then you should be able to see the tip of the NG tube underneath the diaphragm. You can't say, I see NG tube and there is 3 out of 4, but I can't see the NG tube tip, so it's fine. You know, I got 3 out of 4, so we can start feeding. No, you should be able to see all 4 of these on a chest X-ray. If you're in doubt, you should either request another chest X-ray or discuss with a senior. Okay, so this is another NG tube position. So do people think this is normal or abnormal positioning? Okay, as you can see, the NG tube is crossing. It's crossing in the midline. This is the point of carina, so it is bisecting the carina. It's not really changing course, so that's a good sign. However, the tip of the NG tube is here, so it is somewhere in the distal esophagus. So in this case, only 2 of the 4 rules apply. It crosses the thorax in the midline and it bisects the carina, but it doesn't cross the diaphragm and you can't see the tip underneath the diaphragm. So this is not a normal position. So in this case, you would need to advance it a little bit further and repeat the chest X-ray. Okay, what about this one? Is this normal or abnormal? Okay, so well done to those who said this is abnormal. So it crosses the thorax in the midline, that's good. It looks like it is bisecting the carina, but if you notice, at the point of carina, it is changing course. If it was normal, it would have just gone straight down without changing without changing direction, but it is changing course at that point. So this is actually following, as you can see, it's kind of parallel to the left bronchi. So it is following the course of the bronchus. This NG is actually in the left lung. Although you can see the tip underneath the diaphragm, but again, thinking back about those 4 rules, 2 of them apply here. It goes through the thorax in the midline, and it is underneath, you can see the tip underneath the diaphragm, but it doesn't quiet bisect the carina, and it doesn't go through the diaphragm in the midline. So this is abnormal. Okay. All right, so we got another case now. We got a patient in his 40s with a 2-day history of shortness of breath, cough. You will speak to the nurse, and she says his temperature currently is about 37.6, so not very exciting. His white cell count is about 16, neutrophil is about 10. His lymphocyte is normal, and he hasn't had any recent hospital admissions. So what do you think is the most likely diagnosis in this case based on this chest X-ray? Okay, so we got a lot of disagreements on this question. So a lot of E's and a lot of D's. So a lot of people have said E. Would you think someone has lung cancer based on a 2-day history and nothing else? No other red flags. It's not very likely, is it? So it could be lung cancer. Is an area of increased density. Could be anything. Could be pus. It could be cancer cells. Could be infiltrates. But we need more information on that. And possibly, if you want to rule that out, we need to repeat the chest X-ray in usually about 4 to 6 weeks' time to rule out lung cancer. So the correct answer is D in this case. So as you can see, there is an area of increased density in the mid-zone of the right lung. We can see some cavitating lesions, some air bronchogram in it, which basically means the airway is patent and the lung is not, or that lobe is not collapsed. There is a small right-sided pleural effusion. So how can you see that? Is the costophrenic angle should be an acute angle. If it's not an acute angle, so if it's like 90 or if it's like this, which looks like a bit rectangular, then that is a sign of pleural effusion on that side. So we have a bit of pleural effusion. We have area of increased density in the mid zone. The patient has had the thing that is quite misleading in this question is the temperature, isn't it? It's 37.6. But I see this many times. The patient comes through A&E. They've already had a few doses of paracetamol before coming in, and they look apyrexial, or the thermometer machine is not working properly. So a current temperature, one-off temperature of 37.6 doesn't mean anything. Okay, you need to have multiple readings, and you need to have accurate readings. Okay, so this patient's temperature without paracetamol masking it would probably be around maybe 38, 39. As you can tell from the blood results that we've got increased white cell count and neutrophils. So, and this looks to be more like a bacterial infection because of the leukocytosis, and the lymphocyte is normal. Usually in the case of COVID, you see a reduction in lymphocytes, but we don't see it here, and you don't see bilateral changes here. So this is most likely community-acquired pneumonia. And why is it not hospital-acquired? Because the patient hasn't had any recent hospital admissions. It's not from a care home, and it doesn't look like CCF. We're going to come back to CCF, but the heart looks normal in size, and there's not increased reticular pattern bilaterally. Okay, so in this case, what you need to do is, and this patient actually had MRSA positive pneumonia, which is quite rare, but some young patients of influenza can get that. And what you need to do is you need to get a CARB-65 score, triage the patient based on that. You can either send them home with oral antibiotics, or you can admit them for further review. Okay, so as Rishi said in his previous talk, consolidations basically means increased areas of high density, and it basically means the air spaces are filled with something. It could be pus, it could be blood, it could be fluid, and we don't fully know. There are things that we need to know about consolidations. What territory are they in? So this is a lobar consolidation on the left picture. So it is a right upper kind of zone consolidation, which could be, most likely could be either an infection or could be cancer. Sometimes we have diffuse consolidation. So as you can see in the middle picture, this could be due to either very severe infection, or sometimes it could be because of congestive cardiac failure. And sometimes you can have these multifocal areas of consolidation without any continuity in between them, which usually point at a more chronic picture, such as cancer. And as I said, the clinical picture and the history is very important. Is it an acute or chronic problem? Do they have fever? Is there any hemoptysis? Is there any weight loss? Without that, you wouldn't be able to tell what the cause of the consolidation really is. So don't jump into saying, oh, I see a area of increased density, so that's pneumonia. Okay, you don't know yet, so you need more information. If it is a lobar consolidation, statistically, the most common cause of that is pneumonia, but it's not necessarily pneumonia. And it could be other things, as I said. It could be cancer, it could be hemorrhage, sarcoidosis. So for instance, in this picture, there is a consolidation in the right upper zone. This is pneumonia. This looks very similar, doesn't it? Another consolidation in the right upper section, but this is pulmonary hemorrhage. But you wouldn't be able to distinguish between them, would you? So you would need more information, really. And then we've got these kind of multi-nodular kind of consolidations in mid zones and lower zones. In picture 3, this is because of organizing pneumonia. And we can have things such as pulmonary infarction that could look like consolidation, and cardiogenic edema, which could look like consolidation, and sarcoidosis. So it would depend on the clinical picture, as I said. So next case, 68-year-old, admitted with shortness of breath, temperature is 36.8. He's got a cough productive of white sputum. His neutrophil count is 7, his white cell count is 9.2, his CRP is 8. He hasn't had a recent hospital admission. This is his chest X-ray. What do you think is the abnormality? So a lot of C's and D's. Okay. Right lower lobe pneumonia. It could be, but it doesn't look very convincing, does it? It's not. There is a. I agree. There is an area of high density here, but it is not the most convincing pneumonia that I can think of. So this is a CCF. Well done to those who said it is D. This is characterized by a few things. Sometimes you can see all of them, sometimes you can see only a few of them. Sometimes it is very mild CCF, sometimes it's very severe CCF. So it really depends on the severity and many other factors. So the most important thing is usually you see enlarged heart, so increased cardiothoracic ratio, as Rishi said. It should normally be less than 0.5, so the diameter of the heart divided by the diameter of the thorax at the longest point. It should be less than 0.5 in a PA radiograph, but if it is not, which is in this case, then that is a sign of cardiomegaly. The other thing that you can see is something called Kerley B lines. So these are basically kind of reticular patterns which show that there is fluid in the lung. There are different types of Kerley lines. You can have Kerley A, B, and C, depending on the positions in the lung fields. Kerley B lines are usually the most peripheral types of Kerley lines. So you would expect to see them most peripherally, as you can see here, being shown by the blue arrows. The orange arrows, they show Kerley C lines, and the yellow arrows show Kerley A lines. So if you see this, this means there is a lot of pressure and a lot of fluid in the lungs, which shouldn't be there. The other thing that is something that is commonly seen is vascular redistribution. So the upper half of the lungs, you would expect to see vasculature that is less prominent than the lower half. That's because of the effect of gravity. But if you see vasculature that looks as prominent as the lower half of the lung, then that would mean that there is an element of vascular redistribution. So there is pulmonary hypertension because of heart failure that is causing increased density in those vasculature. The other thing that is very commonly seen is, as I said, blunting of the costophrenic angles. So coming back to that, the angles should be acute, but in this one you can see it's kind of 90 degrees or a little bit more than 90 degrees, kind of actually obtuse angle. And this one also, there is area of high density around it, and you can't really see the angle properly. So we've got bilateral pleural effusion as a result of the heart failure causing the blunting of the costophrenic angles in this case. The other thing that you can see is if it is very severe, you can see areas of consolidation in the prehilar region around the heart. So as opposed to COVID, which is areas of consolidation peripherally, usually in the lower zones, these are areas of consolidations in the prehilar regions around the heart. So if you see this is a case of very severe pulmonary edema. This patient is very unwell. The other two things that you can also see is something called pre-bronchial coughing and vessel to bronchus ratio, which I'm going to go through very quickly. So this picture on the right, this is a bronchus, and you can see the wall of the bronchus is very well defined. It's quite thin. It's not hazy, so that's normal. But in terms of the congestive cardiac failure, you can see that the bronchi, they look like they have thick white halos around them. So the walls are thick, they are very hazy, and there are a few ones here as well. So that's another sign of congestive heart failure. And another one is vessel to bronchus ratio. So usually the vessel, this is a vessel on the left, and on its right as the bronchus. So usually the vessel should be smaller than a bronchus. But in terms of heart failure, the vessel would be bigger than the bronchus immediately adjacent to it. So that's another sign that you can find. None of these signs are 100% sensitive or specific. It could be caused by a variety of things, but if you put everything together and the clinical picture and presentation and history, then it becomes quite clear. I think I'm running out of time. Just going to quickly go through this. So the other thing that we can see as well in chest X-rays is something called atelectasis, which basically means collapse of a segment of the lung. Could be a very small segment, or could be the whole lung on one side. So this is a very common one. This is the collapse of the left lower lobe. When this happens, usually we get an area of increased density around it. And also we get something called the sail sign, which is a triangular shape that gives the impression that we've got two heart borders. So if you see this triangular shape, which is the sail sign, that is indicative of atelectasis of the left lower lobe. So I'm going to quickly go leave that for now. There is another one that we see quite commonly when it comes to atelectasis. It is the right upper lobe atelectasis. So usually this is defined by an area of increased density in the right upper zone medially. And we can also see the elevation of the horizontal fissure, so which means that the inferior border of that increased density area is quite sharp. Okay. And then we can have things such as elevation of the right hilum on that side. It can go up a little bit, and elevation of the right hemidiaphragm or tenting of the right hemidiaphragm, which we can see in this case. It's a bit tented and it's a bit sharpened as well in the middle. And on the side of the atelectasis, there is general loss of aerospace. So the air area on this side is very smaller than the air area on the left side. So a lot of people would mistake this for pneumonia, but this is actually a lung collapse on the right side. Now this is a picture of the total atelectasis of the right lung. As you can see, there is complete whiting out of the right lung. And the thing that would point towards it is that the mediastinum and the trachea is deviated towards it. In this case, you can see that's the trachea here. So that would point towards a lung collapse rather than anything else. Okay, final question. I hope you can see this one. Patient has come in with sudden shortness of breath, 31-year-old, pleuritic chest pain. What is going on here? Yeah, it's interesting that some people have said it is PE. Probably just because I said the word pleuritic chest pain. So you wouldn't diagnose PE only based on a chest X-ray. You would need more information. You would need probably D-dimer or CTPA. But it is actually something that is anyone who comes in with kind of sudden onset of shortness of breath and pleuritic chest pain, something that needs to be considered, definitely. But in this case, looking at this chest X-ray, you can see the pleura, the line there, and beyond that, you can't see any vasculature or anything. So this is a case of left-sided pneumothorax, this patient. And if you have this, then what you need to do is to calculate the size of the pneumothorax and find out if it is a primary or secondary type of pneumothorax. And based on that, you either aspirate, manage conservatively, or put a chest drain in. Okay, thanks very much. Any questions?
Well, thank you very much. I think if people don't want to put a message in the chat or whatever, they should have the ability to rename themselves and then they can post it anonymously. But there are questions coming through.
Are there any questions?
So someone's put in the chat the right RUL collapse. Is that S sign or is that for something else?
Sorry, can you repeat the question? I didn't hear.
The question is, in the right upper lobe collapse, is that S sign or or is that for something else? I think they're asking, is it an S sign in the right upper lobe collapse, or is that a different thing, or is that something that?
Yeah. Sometimes you can call that the S sign. It is not very commonly used by radiologists, but some people refer to it as S sign. Yes.
Okay. And someone else has put in, what's the difference between atelectasis and pneumothorax?
So a pneumothorax, there's air actually in the pleural cavity. With an atelectasis, it could just be a simple collapse of a part of the lung, but doesn't necessarily have to be air in the pleural cavity.
Another question, how do you measure the size of a pneumothorax when it's in the apex? So I think this is asking about sizing pneumothoraces, how it's different in America to here, whether you measure from the axilla or from the apex.
I'd always just measure from the biggest point I can. Because when you get the measuring tool out on the proper computers, you can I'll just use it to go from the biggest point.
Any more questions? Don't think so. Okay, perfect. That was really useful. Thank you very much for going through it. It was really good to get the structure and then also try and test it on some cases which are really interesting and pretty varied. So good stuff to know. Jemima has put the feedback link on the chat. So if people can fill that out, then we'll be able to make sure that slides can actually get to people. And it's also really helpful for the speakers. Yeah.
But the one thing I forgot to mention on tips with any radiology, you'll notice radiologists do it. Just be as vague as possible. As I said, always go zones, never say lobes. Say in areas of increased density, never say that's a pneumonia, that's a cancer, because you don't know. So always just say that's an area of increased density and say that might suggest this, but never go too specific. Be very vague. That's another thing I could think of as a helpful tip for OSCEs and things like that.
Yeah, please fill in the feedback form, guys, when you can, and we'll send over the slides.
Yeah, feedback is very useful.
Wonderful. I think what I'll do there is stop the recording if you're happy. If anyone's got any final points, then we'll just stick around for maybe a couple of minutes longer if that's okay with you, just to see if anyone's got any